welcome Dr. Juan Sanchez-Ramos.
Good afternoon. So I printed out the questions. Before I start getting into them and being really succinct, I just want to point out that if you have a keyword in your question, you can go to the Parkinson Research Foundation, ask the doctor for frequently asked questions, and it's amazing what you'll find, really detailed answers that go back for when Abe Lieberman was the medical director. So we have a whole archive of frequently asked questions. So one of the questions that was raised, the person could have gotten a detailed answer, but they'd rather ask me in person because I guess I have a lot of colorful delivery. But here's what the question is. Number one, my husband has Parkinson's and polio, post-polio syndrome and mixed sleep apnea. So he's had polio, has Parkinson's disease, and has what is called a post-polio syndrome, along with sleep apnea. He used to live in Sarasota and Palmetto, Florida, and we've been receiving emails from you regularly. That's from Parkinson Research Foundation. The Parkinson's first symptoms were in 1993. He was diagnosed in December of 2000 in Sarasota. As a founder of Polio Survivors Network, I would like to ask Dr. Ramos, how many Parkinson's patients is he aware of that also have polio? We are aware of 5 people that have both polio and Parkinson's disease. Are there any medical articles or advice you could suggest to add to our knowledge? I believe I'm right in saying that 30 years after Icelandic disease, that Parkinson's went up 30%. Icelandic disease was labeled in North Iceland, but 2 years later, it was an outbreak of polio virus that caused paralysis. It was realized that Icelandic disease was nothing but polio. It's funny, the Icelandic people are Viking descendants, and I guess are very self-centered. They get polio that they never had, and they call it the Icelandic disease. It's a worldwide disease, but anyway, that's Iceland for you. Iceland is not only cold, but it's isolated, an island of Viking refugees. And I laugh about the the Icelanders, because the chairman of my department at the University of Chicago, named Arneson, was an Icelandic person, and one of the neuropathology professors was Icelandic. He was about 6'7", huge man with a horrible personality, and he looked exactly like a Viking, and he was really nasty. So I have that residual kind of angst about Icelanders. So here's the answer. I just put in, because I remember this has been asked before, but I didn't know how long ago and what the answer was. So I pulled it up on our website. You can all have access. Remember, keywords under frequently asked questions, you'll come up with gems. Dr. Abe Lieberman, who has provided answers in this blog for many years, was interested in the relationship between polio and the development of PD. One of the reasons, he had polio as a young man, and he walks with a limp. But he had polio, and he has known people who have had polio, got over it, they're left with some residual muscle atrophy and wasting of muscle. And then when they get to the right age, or the wrong age, they develop Parkinson's disease. So he wrote an article in 2009. He wrote in this Ask the Doctor blog, he wrote, quote, "No one has statistics on the prevalence of post-polio and Parkinson's disease." So that's the answer to the first question. The majority of people with Parkinson's disease do not have a history of polio or post-polio syndrome. And for more reading, there's a website you can go to. There's a really nice long article, but I'll read you excerpts from it. During the polio epidemics of the 1950s, many of you probably remember that, there were several small outbreaks of patients having drowsiness, prolonged sleeping, slowing the brain waves, as well as some of the symptoms of both bulbar polio. Bulbar polio is when it affects the brainstem, you have weakness of facial muscles, breathing, etc. It's a little different than limb polio. And all polio is it's a viral infection of motor neurons in the spinal cord or motor neurons in the brain. So it spares sensory neurons, and typically does not affect thinking, cognitive function, and so forth. So, but the bulbar polio had a certain kind of made people think a bit about Parkinson's disease because they had some rigidity and tremor, which was something new to me. In 1952, type 2 polio virus was isolated from one group of patients having these symptoms. It was found that neurons in their brain activating system had been damaged. So it turned out that our concepts of polio being a purely motor neuron disorder was not correct in this type 2 polio, which also affected interneurons that had to do with arousal and level of awareness. So the association of decreased brain activation and Parkinson's disease symptoms remind Dr. Oliver Sacks, who many of you know of the sleeping sickness patients with Parkinson's disease that was described in his famous book Awakenings that was later made into a film. And to clarify that, there was an epidemic of a viral encephalitis 1917 to 26, where millions of people around the world died. In fact, my grandmother died of that. My grandmother died of that when she was very young, in 1925. So people who survived that encephalitis, called the sleeping sickness, had many different names, would develop Parkinson's disease. And for years, the most common cause of Parkinson's syndrome was a viral encephalitis, survivors of that. And it was believed that all Parkinson's disease was probably due to a virus. The virus that caused the sleeping sickness had a certain overlap with type 2 polio virus, right? So that could mimic some aspects of the Parkinson's syndrome seen after other viral infections. So, however, it was predicted that as the people who had suffered from this encephalitis would die, that the newer generations would not have Parkinson's disease and that the frequency of Parkinson's disease would diminish. They were proven wrong because it's actually very unusual to see viruses as the cause of Parkinson's disease. We still see this every now and then. So a serious viral encephalitis that causes you to be kind of in a coma and you recover. For example, West Nile virus can cause Parkinson's syndrome, but it's extremely rare. So we now know that Parkinson's disease can be caused by many environmental factors, and pesticides, herbicides, genetic factors, and a bulk viruses, drugs, etc. The bulk of the cases of Parkinson's disease, 80% of the cases that we see, we can find no cause. They never had encephalitis, they never had polio, they never had any other insult to the brain. So Parkinson's disease patients, you know, have problems in the deep gray structures of the brain, especially in that part of the brain where dopamine is made, and that part of the brain that's responsible for automatic movement without you having to think of those movements. And Parkinson's disease patients have something really in common with post-polio syndrome. Now, here's what I mean by post-polio syndrome. It's a disorder after people have recovered from the polio decades ago. When they get to middle age, they start having a sense of fatigue, really easy fatigue that resembles the fatigue seen in Parkinson's disease. This excessive fatigue has been reported by 48% of Parkinson's disease patients. And 1/3 of Parkinson's disease patients report that this debilitating fatigue is probably their biggest problem. And many of you can think of that and how levodopa helps that sense of fatigue or not. In fact, it makes some people even drowsier and more tired. One of the first descriptions of Parkinson's disease could serve as a definition of post-polio fatigue, characterized by diminution of voluntary attention, spontaneous interest, initiative, and the capacity for effort and work, significant and objective fatigability, and a very slight diminution in memory. That was how some of the early cases of Parkinson's disease were described, and it's very similar to what post-polio syndrome is. So that was all in our blog that Abe Lieberman produced. So the question, that was asked for this session could have been answered, but it was worth bringing it up. Makes my life easier. I just have to put the keyword in. I didn't have to Google it. If it's not in the keyword, then I'll Google it and pick out reputable sources. Many of you can do that. Don't be afraid of Googling keywords, but make sure you don't believe everything you read. Try to pick something that has a journal of neuroscience or neurology and has an academic origin. It's more likely. If it comes from a company in Timbuktu that promises you a cure, be careful. Avoid it. Here's the next question. This is, I don't know why, I must have a bad reputation, a certain reputation. It says, there are 2 questions out of 9 that I picked that have to do with this issue. Can long-term, 40-plus years of daily marijuana use cause Parkinson's disease? There's got to be some jokester in here. Well, as far as we know, it doesn't. In fact, as I've mentioned in the past, there are components in cannabis that are neuroprotective. And there are going to be eventually studies done that look at the cannabidiol as a neuroprotective agent, perhaps in Parkinson's disease. And in that case, that is not something that makes you high or alters consciousness. Cannabidiol has no psychoactive effect. So it wouldn't be as much fun, but it might protect you against Parkinson's disease. Here's another one. I put the 2 cannabis questions right next to each other. Good afternoon. My grandmother is worsening from her Parkinson's condition. Now I'm looking for alternative treatments such as cannabinoid oils. Could you recommend the best doctor in this area? I do not know any doctors who are experienced with PD who are also, this is my answer. I do not know any doctors who are experienced with PD who are also knowledgeable about cannabis. Except me, I know a bit about it, but there's no way that we can utilize cannabis in its various formulations as a treatment for Parkinson's disease in the state of Florida. In 18 states, it's possible, and Washington, D.C. And in 2 of the states, it's available to anybody. It's a recreational substance. But I would recommend that, here's what she wanted to know. How do I go picking a place where I could go? You know, so I say the best, I would suggest that you go to the state of Washington. Because she says can go anywhere, right? Seattle, where she could see a neurologist to document the illness. And then once the illness is documented as Parkinson's syndrome with rigidity and muscle spasms, the patient is eligible to register with the cannabis dispensary. And then she can consult with the cannabis dispensary as to the best preparation for her, which I would think would be a tincture of cannabis that you put in tea and you drink it 3 or 4 times a day. Brownie. Yeah. Yeah, that's Alice B. Toklas' approach. Yeah. So that's the end of cannabis discussion for now.
A footnote, since we came from Seattle, and then put a footnote, they'll be back to Sarasota.
Why, Seattle's too dreary and wet and cold?
Yeah. You got it.
Yeah. Okay.
They don't have the proper, the wealth of resources
that you have
for Parkinson's here.
Yeah.
So that's where you came from there to here. So
I see. Well, what there is, and this is, I don't want to bring up cannabis anymore. People will think because I am a child of the 60s, and but the fact is, there's a lot of clinical research that needs to be done before we can feel comfortable in prescribing it for various conditions. Let's go to the next question. How do I go about picking a place to have DBS, deep brain stimulation? It's a very good question. First of all, I just want to preface it by saying that not everyone with Parkinson's disease is a candidate for DBS. The criteria, or what is necessary to be a candidate for DBS, is that you have to have shown a good response to levodopa carbidopa, or a dopamine agonist. And the way that's assessed when you visit a center that does deep brain stimulation is they'll have you come in without any medicine, so that in the morning you're completely off. They give you a trial dose of Cinnamon, and examine you at various times. And if you get better by 30% in terms of the motor symptoms and signs, then that means you are dopamine responsive, which means that you have Parkinson's disease by definition, which is slowness, rigidity, that gets better with dopamine replacement. There are many people with slowness, rigidity, and tremor that don't get any better with cinnamon. That's atypical Parkinsonism, such as vascular Parkinsonism or some other variation. So that's the first thing. If you've responded to levodopa and you still respond to levodopa, you can have DBS. It seems like, well, why do I want needles in my brain if I already get better with Sinemet? It's because you need the second criteria, which is that when you take Sinemet, the on is too short, you wear off frequently, and you develop dyskinesias. So when you have motor fluctuations in response to levodopa, and you're up and down like a roller coaster, and it's punctuated by dyskinesias, which are excessive involuntary movements, that's the ideal candidate. And finally, there are exclusion criteria. So you have to respond to levodopa. This is before I even tell you how to find the place. This is, you discuss this with your neurologist. And while you respond to levodopa, you have complex motor fluctuations that you haven't been able to solve with your neurologist to stabilize your response. And you're not demented. So the other thing they do is make sure that you don't have any significant cognitive decline. So they do a neuropsych battery. Anyone who would do DBS without doing these three things, and you know what? They're doing it. Anyone that's a neurosurgeon, has the equipment, often take anybody with a rigid kinetic syndrome without seeing if you're responsive to levodopa, have motor fluctuations, aren't demented. So that's going to help you choose which place to do it. Now, how do you choose the place? First of all, you should look at where you're going to live, because you need to go frequently for follow-up. You need to go at least initially pretty frequently, and then every 6 months. And if you have it done, let's say in Baltimore at Johns Hopkins, but you live in Seattle, that's kind of ridiculous, isn't it? Because every time you need a tuning up, you'd have to fly, because you don't want to have someone adjusting it who doesn't have the experience. And the tuning up is very, very critical. So I would decide where you're going to live. Many of you have already decided. Let's say it's Sarasota. So you have a number of choices in Sarasota. We have a Dr. Schumacher who used to do it, but he's in transition. I don't know if he's going to continue to do it, but he had a very good track record, especially when he had a neurologist who worked close with him. It may be he'll be able to start that up again. But I referred a number of very difficult cases to him. They did well. I even referred a patient who had the fetal cell grafts done about 25 years ago. And then he continued to have really severe motor fluctuations. And most of the neurosurgeons didn't really feel comfortable to do DBS in someone who already had multiple needle probes on both sides of his brain from putting in the fetal cells. But he did a subthalamic nucleus stimulator and did very well. The next place that's, I'd say, average, not great, is the University of South Florida. And that's where I am. And there are two neurologists, neurosurgeons that do that. And they have, here's why I say they're average. The surgeons are very good. But there's no one there other than a nurse practitioner who often brings in Medtronic's representative, technical people to adjust with the tuning. And as long as the Medtronic's people are there, they do very well. So people in Tampa are doing better and better that I've referred to the University of South Florida. The prime place in Florida is Gainesville. Dr. Kelly Foote and Michael Oken. Oken is a neurologist who's very, very dedicated to deep brain stimulation. And many neurologists aren't, like myself. I am a pharmacologist. I like medical approaches. The surgical approach takes a certain personality. Michael Oken is very careful. He goes into the OR with the neurosurgeon. He does the microelectrode recording to make sure that the site is correct. And they have a great program. So if I had a member of the family that met all the criteria for deep brain stimulation, I would send them to Dr. Oken. So that's how I would do it. Now, depends on where you live. The first choice would be an academic center within 100 miles of where you live, so you could drive for follow-ups. Second would make sure they have a lot of experience and that they follow all the correct criteria. And that's how you choose. If you don't mind flying to a place that's fairly distant, well, you could do it that way as well. Just have a local neurologist to manage the medications. Because even though you have DBS done, you're not home free. You still have, it doesn't solve everything. That's the other thing you should be aware of when you're thinking of DBS. Number one is it may not improve gaining balance. In fact, it won't. Number two, sometimes you can have cognitive changes. That's why a decline in cognitive function. So those two things are somewhat worrisome. And that's why you have to make sure there is no underlying cognitive decline other than the minimal amount that is present in Parkinson's disease, which is okay. I'll go to the next question. What are the best ways to counter sleeplessness and insomnia? He says, or to stay awake at night. How to counter staying awake? Well, this is actually a very everyday question that we're asked. I'm asked in the clinic. And insomnia, or I shouldn't say insomnia because a lot of people don't realize it's an insomnia. They have a sleep disorder where they have fragmented sleep. They wake up many times during the night. They usually say it's because they have to go to the bathroom, which is partly true. And then frequent daytime napping. And about 80% of individuals with this abnormal sleep who have Parkinson's disease have what's called REM behavior sleep disorder, which is a more detailed analysis of the sleep problem. And what it means is that your dream sleep, which is rapid eye movement sleep, well, see, when you're dreaming, which occurs every 90 minutes in a healthy person, just before you wake up, your eyes start fluttering, but you're completely paralyzed. And your brain waves look like you're awake. So it's a waking electroencephalogram, but you're dreaming. And if someone was to, this was discovered at my old alma mater in the 1950s, where they were doing very profound polysomnograms during the night. And they found that if they woke someone during this phase of sleep called REM sleep, they could recount in great detail their dream. So what happens in Parkinson's patients, their REM sleep doesn't occur at the normal phase, and sometimes it can occur while you're awake. So you're kind of immobile, your EEG's conscious, you start seeing things. There's no way for you to validate whether what you're seeing is real, and so you have a hallucination. So people with REM behavior sleep disorder are more prone to visual hallucinations when they're awake. It's like dreaming while you're awake. They also have really abnormal sleep architecture in another way. That REM sleep doesn't occur every 90 minutes. In fact, they never get into the deep sleep. They never get into phase 3 sleep, the deepest sleep. When you go to sleep, your brainwave activity gets slower and slower until it's only 2 to 3 cycles per second. If I look at an EEG, I can see if someone's asleep by just looking at the waves. I can see if they're dreaming by looking at the brainwaves. So what happens in people with Parkinson's disease is that when they do have the REM sleep, in the middle of their cycle, because it can occur even while awake, but if the REM sleep occurs, let's say 30 minutes, they haven't reached deep wave sleep, but they turn on the REM, but they don't inhibit the motor function. So that what do? They yell out, they thrash, they fight, they kick their spouse out of bed. So that is REM behavior sleep disorder. There's thrashing, kicking, acting out, vivid nightmares, and you act them out. So this is a real problem, very common. But even before it gets to full-blown, acting out, screaming in your sleep, it can have, you can just see it as fragmented sleep. They're never quite rested, never get restorative sleep. So one of the best ways to do it, to treat that kind of sleep disorder in Parkinson's, is a drug called quetiapine or olanzapine. That should be used in very tiny doses, and that often solves the sleep problem. Even in people that don't have REM behavior sleep disorder, for REM behavior sleep disorder, it's ideal. A lot of sleep doctors use clonazepam, clonazepam is only good for about 2 to 3 weeks, and you become tolerant to it. It's a benzodiazepine. It's a child of Valium. You know, it's a derivative of the same structures, and they're seen as depressants. So they're good for a short term, but for the longer term, it's better to use a drug like Seroquel or something related to it called olanzapine. Let me finish this. Now, if you have just poor sleep and you don't really have any of the characteristics of REM sleep disorder, I recommend for everyone, which I recommend for healthy people, is good sleep hygiene. And what does good sleep hygiene mean? It means that at night, there's no lights. You turn off all the lights, even those guide lights that you put on because you're afraid you're gonna fall. No lights, and during the day, you open the blinds, let the sun in. Reason that's important is that at night, when there's no light, and I notice this in my birds, which are so sensitive to the light, they all climb into, when the sun goes down, they climb into they just fall asleep as soon as it's dark. And what happens is, in all of these vertebrates and mammals, the levels of melatonin are produced in the pineal gland, which is like the third eye, sensitive to light, dark. Unconsciously, there's a little branch from your retina that goes to the third eye, the pineal gland, that makes melatonin. Melatonin gradually increases when the darker it gets, but if you turn on a light for 2 minutes, turns off melatonin. You're not going to sleep, because melatonin is a sleep-inducing compound. So you never really want to turn on the lights. Once my wife learned that because she's a chronic insomniac, and she's already in bed. If I turn on the light, she'll really get upset because you're interrupting my sleep. You know, and in fact it does. So that's one part of it. But if, and I'm going to take some.
Obvious point here. Why wouldn't we use melatonin then?
Well, that's what I'm saying. That's what I was going to follow with that, saying that you can use melatonin 2 to 4 milligrams at bedtime, but make sure you turn off the lights. And if to induce sleep, sometimes it's helpful, a very benign thing, better than a clonazepam or Valium or Ambien that your family doctors love to use, I would recommend Benadryl, 50 milligrams, which you can get in Tylenol PM. And Benadryl is a very nice aid, especially in Parkinson's disease, to get to sleep. And it also dries up secretions a bit, so all of the postnasal drip and excessive salivation has helped a bit. So that's when, okay, we'll go to the next question. See how we're doing. When having surgery with Parkinson's disease, which anesthesia would be appropriate for injecting in the back? I wouldn't want anything injected in the back. They're talking about intrathecal administration of an anesthetic. That means it's a spinal block in a sense, and putting into the cerebral spinal fluid through an lumbar puncture and infusing an anesthetic. Usually it's a local anesthetic. It'll anesthetize everything below a certain level. So if you're going to have prostatic surgery or surgery in your private areas, you don't need to be under general anesthesia. Or surgery in the lower extremities, you don't need that. If you're going to have just, say, surgery on the arm, you can have local nerve block. You don't need to have general anesthesia. But if you're going to have intrathoracic in the chest, or abdominal, or brain, or head and neck, you need general anesthesia. So, and what is the anesthetic? That's up to the anesthesiologist. He'll decide. But the anesthetics used for general anesthesia are gas anesthetics generally, but there are some that are short-acting, that are intravenous, like propofol, for very short-acting anesthesia, or the intravenous drugs versus inhaled. They're general anesthetics. For local anesthetics, they tend to use what are drugs kind of like lidocaine type of drug, like what your dentist uses. But when it's put into the cerebral spinal fluid, depending on, if you stand on your head, that's not good because all the fluid will go towards the head, then you'll have an issue. But generally they know to position you when you're going to have spinal anesthesia. It's what's done to help in childbirth as well when the pain is intolerable. They'll put a spinal tap needle in there and infuse a little bit of a local anesthetic, and the woman won't go through that terrible pain. So, okay. What I mentioned is another term for this is spinal anesthesia, also known as an intrathecal injection, because the spinal cord and the nerve roots that exit at each level are covered with a sheath, a membrane. And between the membrane and the spinal cord is cerebral spinal fluid that bathes the brain and the spinal cord and the nerve roots sleeve. So if my arm is a nerve root coming out, this is the sheath, and the cerebral spinal fluid would be between my sleeve and the arm. If you have, I don't know how many of you have had spinal taps, when they take cerebral spinal fluid out, it takes a while to recover it. You get terrible headache because the CSF has a buoyant effect and allows your brain to float a bit. If you take it out, your brain is kind of hanging heavy and it hurts. Headache. Here's another question. Some of the questions are amusing the way they're phrased, but you can tell they're quick off the top of the head and perhaps not great at the keyboard. So I'm reading it as it says. It says, is cognition problems part of Parkinson's, and what can be done for it? You all know the answer to that, but I'll tell you about it. Is there a cognitive problem? Is there problems with intellect and thinking in Parkinson's disease? And it's a very, very important question, because for a long time we thought there was none. And in most people, it's very minimal, but in a small fraction of people with Parkinson's disease, it's pretty profound. It looks like Alzheimer's, if not even worse. When it's very profound, the cognitive decline appears even before the Parkinson's syndrome. In other words, before the motor symptoms. And usually if people start having a lot of dementia with visual hallucinations before taking any medication, and personality changes and paranoia, and then they're examined by their doctor and they have cognitive rigidity and slowness, usually that's going to be dementia with Lewy bodies, which is not that common, but it looks like a combination of Alzheimer's disease and Parkinson's disease. But most people with Parkinson's disease don't have that kind of profound cognitive decline in all dimensions. There are 5 domains, I say dimensions, or fields of intellect or thinking. And when you have a real marked dementia like in Alzheimer's or in dementia with Lewy bodies, you lose intellectual function in all domains. That means in your short-term and long-term memory, in spatial perception, abstract thinking, numerical calculations mentally, all of that goes. Executive function, planning ahead, carrying through, multitasking. That would be a global dementia. In Parkinson's disease, the dementia, when it occurs, but dementia, by the way, I have to put an aside here. Patient saw me yesterday. First question he asked me, do you think I'm demented? Actually, he was, but I got, but he was concerned about it, and I said, well, let's see. Others have said you are demented, but we'll see. Let's see where you have dementia. And I said to him, well, dementia is nothing but a decrease in your intellectual capacity. And since we have a normal decrease in intellectual capacity with aging or from disuse, mostly from disuse, compared to when you were 30 or 40 year old, let's say 40 years old, and now you're 70, and you wonder, is my mind as sharp as it was when I was 40? And some people it is, because they've continued to use it. In fact, maybe even sharper. They've honed their skills, their cognitive capacities. And some people, they didn't ever have that much to begin with and never honed it. Those are the ones that, in fact, there's an interesting study of Alzheimer's nuns. I don't know if you've heard of this study. It's quite fascinating. These are nuns from a convent that agreed to donate their brains after death, and to a group of psychologists. Originally it was Minnesota. And what they did, what was really interesting, is that they did complete cognitive assessments when these people were 60 and 7 years old. They had retired from their teaching in their convent, which is a teaching order. And they looked at the nuns that were demented, mild demented, and seriously demented. And they had the ability to look back at their early high school scores, because from high school you become a novice. And they had the entry exams, and they give them some tests and their high school scores. And the ones that developed Alzheimer's dementia were the ones that were the poorest students. They were the ones that had really terrible grades, that never did very well in school. But they were smart enough to get into the order, whatever that means. So they were able to teach, maybe first grade, second. And those that maintained their intellect or had very minimal tended to be the brighter students. So it may be that early on you can see that the intellect is affected, and it takes a long time before you reach dementia. But that was an aside. In Parkinson's disease, people have normal intellects across the board. The earliest things that you might see in a classical Parkinson's patient is a problem with what we call executive function. Another aside, Janet Reno, when she was told she had Parkinson's disease, she was the Attorney General. And everyone said, won't affect her function. But you know, someone in her position who has to multitask, plan ahead, follow through, should have resigned from that position, because that is definitely affected early. It's always a hard thing to have to convey, that your ability to make these decisions based on review of going from one set of problems to another is compromised as an early manifestation of cognitive decline in Parkinson's. So that's what's most affected. We call it executive function, which is planning ahead, multitasking. Now, people can still do pretty well, especially if they write everything down and they follow through on their tasks, but it is one of the consistent changes. The other consistent change that you see in Parkinson's disease is spatial perceptions. And there's a number of tests that you can do, is, for example, to put the numbers on a face of a clock, to copy a figure, and then there's more sophisticated assessments of visual spatial perception. And people with Parkinson's disease don't do as well early on, and it gets worse with time. So that may be one of the reasons that they tend not to drive as well as the illness, because their orientation of their car in space is compromised. They may not be as aware of what's going on around them as they drive. So they're more likely, and it's well known, to get in accidents. Usually not serious accident. Well, it's bad enough that they could be serious. So that's what I say about, now what do you do about the dementia that we see in Parkinson's disease? And as I say, it can be really bad when it looks like Alzheimer's. And by the way, both Alzheimer's and Parkinson's disease are the two most common disorders that we see in people between 60 and 80, right? So that it's not unusual to have both. Having one doesn't protect you against the other. So if someone has Parkinson's disease, but also it's really the family and the person is concerned about their intellect, well, it's very important to have a neuropsych complete battery of cognitive assessment to see how much of this is related to Alzheimer's versus Parkinson-type cognitive change. So if it's an Alzheimer's type of disorder, where short-term memory is the biggest impact early on, and eventually all domains are affected in Alzheimer's. But early on, it's the short-term memory, and eventually you fail to recognize faces. It can get really bad. There are several drugs that are used. So Aricept is one, Namenda is another. Now, people with Parkinson's disease, we're starting to use Namenda, which was approved by the FDA for treatment of dementia, of Alzheimer's disease. I'm using it in Parkinson's disease as well, with some benefit. It also has the benefit that it may be neuroprotective. There's some evidence. So those are the two most common drugs we use. But what everyone is now stressing, that you can improve cognitive performance by cardio aerobic exercise. It's hard to believe you're doing something physical, but it makes you sharper. How can it be? Most athletes aren't so smart, right? That's a big thing. But the runners, if you've ever dealt with college, long distance runners, or high school, they're smart. They're at the top of the class usually. I always wondered about that. And it turns out that in animal models, if you force exercise a monkey that has Parkinsonism, they recover very quickly, and they make a lot of growth factor in the brain from the increased perfusion of the brain with blood. And not only that, it increases the birth of new neurons in the hippocampus, the one place where you can make new neurons throughout life. But it declines a bit with age. But if you can perfuse the brain by doing cardio aerobic exercise, means treadmill, running, stationary bike, get your heart rate up to 80% of max, and do that on a regular basis, you can enhance memory, you can enhance motor function. And it's a way to fight father time. You know, So that's the big thing that I stress. You don't have to, like, you know, it's such an easy thing to take a pill. But if you're willing to make that effort, or you have someone who forces you to make that effort, because what happens in Parkinson's disease, there's an element of apathy that comes on where it's hard to motivate. So someone has to structure it for you and say, okay, we're going to motivate you to get on this treadmill. You have to do it, otherwise you can't do this. It sounds like then you're treating the person as a child, and that's not right either. So you have to have some good discussions on the benefits. Nagging? Yeah, okay. Yeah. So I think the two medicines plus cardio aerobic exercise. And if you have a hard time maintaining, you know, the cycling on a stationary bike, and you're able to walk with someone, a good brisk walk will be a good start. What? Swimming is great. No, swimming is a very good cardio. What's nice is you can have bad joints and it's not going to, except for the shoulder movement, but you can do dog paddle. You know. So here's another question. Unfortunately, I can't answer this well, but I looked up on Google and then tracked it down to the company. It says, what is the latest information on IPX066? Sounds like a new kind of computer game. It's a drug. And all it is, IPX066, is a time-release Cinemet. It's an old dog with a new collar, is what we say. And the old dog is Cinemet, levodopa, carbidopa. And the new collar is, we can make it release better than sustained release Cinemet, which already exists. And it's already off patent, so that you can get levodopa, carbidopa extended release was generic, but originally it was a patented formulation. And it turned out that individuals who were started on Cinemet CR, controlled release, didn't have that much benefit in terms of not developing dyskinesias. So the reason that we thought extended release would be better than regular is we thought that quick onset and quick offset regular Cinemet is what's responsible for the development of levodopa-induced dyskinesias. That if you had from the very beginning slow onset, slow release Cinemet, you would have less dyskinesias. It turned out not to be the case. The most important factor in developing the dyskinesias has to do with how much neurodegeneration you have. So someone with young onset Parkinson's disease tends to have a lot more loss of dopamine neurons, and they tend to develop levodopa-induced dyskinesias earlier and more severely. So now there's a new formulation that was shown to be better, give you more on time, in other words, without wearing off, than regular Cinemet. But they didn't compare it to Cinemet extended release, would have been the best thing. So here's where they stand. When is it going to be available? I'm waiting, I'm holding my breath till it becomes available. Okay, so in the nearest release I got from the company called Impax Pharmaceuticals was from April 2013. I haven't seen any new releases from them. And I don't really know when it's going to hit the market, but here's what they said. Kind of interesting. They're going to know it in the US as Rytary, R-Y-T-A-R-Y. That's their trade name. They're doing the studies that had this cool name, IPX066. They announced that IPAX and GlaxoSmithKline are terminating their collaboration for the development and commercialization of IPX66 outside the US. In the US, it's going to be known as Rytary, and it's an investigational extended-release capsule formulation of levodopa carbidopa for treatment of symptomatic signs and symptoms, for symptomatic treatment of adult patients with idiopathic Parkinson's disease. It has not yet been approved anywhere in the world yet. So I think Glaxo and Impax will work together in the US to get it on the market. The FDA accepted an NDA, new drug application, was submitted to the FDA. It's one of the last steps before it's approved. In February 2012, in January of 2013, the FDA issued a complete response letter regarding the NDA, and they're working with the FDA on the appropriate next steps. So I don't know how long it'll take, but it's now between the company and the FDA about some issues they must have found about it. But I'm pretty sure it'll be released soon. I don't know how much better it's going to be than Cinemat ER, that's Cinemat controlled release, levodopa, carbidopa, extended release, and now this one. So it's good that you know what this is, so that when you hear friends say, I'm on Ryderry, it's fantastic. You know it's just levodopa, carbidopa, extended release. It might be worth a try. But we have things that have even better extended relief, that is a transdermal patch that really does result in constant delivery. It's not levodopa, carbidopa, but that's an advantage because remember, even though you're on extended release Ryderry, let's say it's available, you just have a glass of milk for about an hour or two, that extended release is not going to get into the brain. It's extended release in the gut and produces nice blood levels. But with levodopa, you always have to worry about transport from blood to brain. Whereas an agonist, say pramipexole, ropinirole, rotigotine, which is the Nupro, the diet does not impact delivery from blood to brains. So, what I do about new drugs like this, I say it's an old dog with a new collar. I'd rather have a new dog with the old collar. That's how I can say it. Okay. One more question, I think. Oh, this is actually a good question. They're all good questions. Patient has issues with temperature regulation, being too cold or too warm. The clincher is mainly in the knees. I say, what is he doing? Praying before Jesus Christ on his knees? No, I don't know. But why just in the knees? That's an interesting question. And I have no good answer. Because all I said is he's either too hot or too cold, but mainly in the area of the knees. Usually the way I hear about too hot or too cold, it's like hot flashes, like in menopause, where people just perspire profusely all over. And even though the temperature is way down, the air conditioner is full speed, and they soak their sheets at night, nocturnal sweats. And then other times, they're just shivering, they're very cold, and no one else is cold. So they have that. And that is a reflection of dysfunction of the autonomic nervous system that controls blood pressure, the amount of blood flow to the skin, a whole bunch of automatic things like bladder control, bowel movement, all of that. So the autonomic nervous system is impacted by Parkinson's disease to various extents. When the autonomic nervous system is affected really early on in a severe way, that's called Shy-Drager syndrome. They have a dopamine deficiency problem to get better on Cinemat, but they have tremendous problems of low blood pressure. So when they stand up, they feel faint because they can't maintain the pressure, because the autonomic nervous system does this automatically. And Cinemat tends to lower blood pressure a bit more. So does every dopamine agonist. So Shy-Drager syndrome, before you can really give them the levodopa and dopamine replacement, you have to deal with the autonomic nervous system. And one way is to give agents that will increase blood pressure. So Florinaf, increased salt in the diet, midodrine. But in this case, they're just talking about hot in the knees. And I wonder what they're wearing. I said, well, it can be so simple at the garter belt. What's going on here? I just don't get it. I've heard of feeling hot in the limbs or in the arms, but localized around the knee. Anybody have an idea? So I can answer this poor person. What I would suggest when they have this feeling hot, that's the only issue that's going on, consider them lucky. So anyway, I'll take one more question.
Well, with that regard, biofeedback thermometer can train changes in the capillary diameter, so the person could conceivably, I've never done
biofeedback,
it, as a practitioner, treated people with biofeedback, and you can make a change from hot to cold by a thought.
Just like a yogi. But that's so true. There's if you can get feedback as to what you want to attain, so you could get maybe the temperature being fed back to you, so you know exactly what the temperature is, and then you can develop different meditative things that allow you to say, now when I'm thinking about Alaska, my knee gets cold, my temperature drops. So then you find out the thought that works, and you can then bring up but it takes a lot of practice. There's biofeedback for getting to a relaxed state is also good. You wear a little cap, get your brainwave activity, and you want to get into real slow, relaxed state. You can learn to find up images that you can bring up that will result in a relaxation. So biofeedback is a good approach. And I think that's all of the written questions. I'll take one more question, spontaneous question from here.
Can you talk about bradykinesia?
That is a fancy word for slow movements.
Right.
And bradykinesia is the hallmark, one of the hallmarks of Parkinson's syndrome. And slowness of movement can be due to many things. And slowness of movement all by itself, without rigidity, without tremor, without loss of balance, might be just because you can have arthritis. One of the ways that you move slowly is because of pain. So slowness of movement by itself, bradykinesia, is useless. However, when bradykinesia is accompanied by cogwheel rigidity, that's associated with dopamine deficiency. And if you replace the dopamine, the bradykinesia improves, the speed of movement gets better, and there's less rigidity. There's not much else to say, but bradykinesia in its extreme is akinesia, which is no movement, which eventually, and difficulty in initiating movement. So bradykinesia is just slowness of movement, but in Parkinson's disease, there's a spectrum of kinesia. There's the no movement, which happens when people are completely off, to difficulty, or we call it gait ignition, difficulty initiating movement can be very difficult. But in the beginning stages, it's just slowness of movement. Everything is, so when I'm reaching for something, it's kind of slow motion. So you know what slowness is. A lot of people say, well, Doc, I'm getting old. Doesn't everyone get slower with age? Well, in general, that's true, and it's mostly because arthritic issues and so forth. So yeah, bradykinesia, one of the hallmarks of Parkinson's syndrome. By itself, it won't tell you anything, other than there might be pain, arthritis, or caution. One more, yeah.
I got here a little bit late, so maybe you answered this already. One of the questions I had, I've had Parkinson's 18 years now, and my first neurologist put me on Stalevo 150s 8 times a day, which was way too much, I know now. Did that hurt me in any way, being on such a high dosage of carbo-levodopa and Comtan?
I don't like to say it hurt you, because there's no evidence that levodopa is toxic. You know, in the early days of levodopa, the big concern is it's worsening the disease, that it destroys neurons, but there's never been any evidence that levodopa is toxic to neurons. So it didn't hurt you. However, it allowed, because you've been on it for so long and use regular release, because it's assimilated quickly and wear off quickly, and 8 tablets a day is not, you're a large man, that's not such a huge dose. So you may have developed, even if you had taken Cinemat extended release, you may have still developed motor fluctuations with dyskinesia. So it's hard for me to guess that, and I think that's it. We'll end it for today. Thank you.